Hi, you guys. We're starting chapter 17 on mechanics of breathing. So we're going to look a little bit at respiratory anatomy, a little bit of a review there, and then spirometry and the tests that you would do for lung disease. We'll look at ventilation, and we'll start out thinking about what it is to be able to bring oxygen from the outside of the body to the inside of the body of a living thing. So if you were an amoeba, it would be pretty easy because you have this huge surface area, you have this one cell, and you would be able to supply oxygen quite easily to the internal organs. Now, the bigger the animal, the harder it gets because the distance of those cells that need oxygenation from the surface gets larger and larger. So it becomes more difficult. So think of a flatworm. Every cell's pretty close. It's close enough to the surface to get oxygen. So that's pretty easy because it's, flat and big surface area. But now you have a frog. In amphibians, if they can keep the outside of the skin moist, then they can breathe through the skin. So that's a good technique also. Now, we're getting bigger and bigger. These bigger animals that have now an internal anatomy. So this is a fish that has gills. It's still internal, but it's an increased surface area that will allow, this fish to remove oxygen from the water. So the bigger the surface area, the greater it is for it to be able to obtain that oxygen. I'm telling you here that in the fish, it's just a folded area. It's just increasing that respiratory surface, right? Now that it's inside. So now we look at ours. First of all, the language, the vocabulary here for upper respiratory anatomy. We would start out with the nasal cavity. So you're bringing air in through the nasal cavity and coming in possibly through the oral cavity also. You're breathing through either one. And then reaching the pharynx. So here, this region of the pharynx is the region behind the mouth, and air is coming into those. And coming down to the region of the larynx, which is the region with all the cartilage here. Those would make up the upper respiratory system. Once we go beyond that and come into the trachea and the branching of the trachea, that would be lower respiratory anatomy. So when we get to lower, you'd want to take a look at this chart and not memorize these numbers, but you think of a trachea coming down and then it's going to branch. So it's going to branch so that it can go into right lung and left lung. So that would be the primary bronchi. And then it's going to branch again going into the lobes of each side of the lung. So those are the smaller bronchi. And it goes branching and branching. Notice how it goes losing some of its cartilage. Those cartilage rings are now gone and it's just pieces of cartilage. And then it'll branch and branch and branch and branch again until you finally reach the exchange surface, which is the alveoli. So this is just sort of for fun. How many do you have? You have one trachea, but once you start coming down into this branching, you see that we've got, 10 to the fourth. This branching is immense. It's the same story of increasing your surface area so that you can reach thousands of alveoli where this exchange is going to happen. If you were to take a cross-sectional area, in other words, get all the primary bronchi, there are only two, and cut it like this, how big is it? It's 2.5 centimeters only squared. But once you get into the alveoli, this branching is so extensive that it's provided a big surface area for exchange. The lung tissue is kind of like a sponge. It's like an air-filled sponge, and these would be the alveoli, and these little grape-like pockets where exchange is going to happen. And you're going to be able to bring air into those, and oxygen will be able to leave the alveoli, and CO2 is what you will pick up at the level of those alveoli. So this is a diagram of that, and you have blood that's coming in that's deoxygenated and becoming oxygenated. So it's going from blue to red and then exiting. So this is always confusing as to which is the vein and which is the artery here, because we always think of vein as being blue, but it turns out that if it's arriving to the lung, it means it just exited the right side of the heart, right? And that's a pulmonary artery that's leaving the heart. So blue is pulmonary artery, and this is pulmonary vein. So the coloration seems backwards, but that is correct. Cells of the alveoli, let's look at those. What are inside those little grape-like pockets? The first type is the one that's most frequent, most common. It's type 1 alveolar cells. They're squamous cells, and this is the actual site of gas exchange with the capillaries. And, I want to go back and slide. Notice how each one of these alveoli, if I was to cut through it, is surrounded by these capillaries. So it's going to be able to, when it comes oxygenated, pick up a lot of oxygen and get rid of a lot of CO2. So these look a little red, a little blue, because they're in the middle of making that transfer. Okay, so think of these little grape clusters as totally covered by capillary beds. So the cells that are going to line that alveolus is going to be simple squamous epithelium. It needs to be simple. We want it to be simple. And that's because I want to write with this, change it to pen. And we want it to be simple because if not, it's going to be very difficult for gases to cross this thick epithelium. So if you have a simple squamous epithelium, that transfer is going to be easily accomplished. So that's type 1. Type 2 alveolar cells are surfactant cells, very important cells within the lung. They are going to secrete this chemical, this pulmonary surfactant. It's actually a phospholipid. And what it does is it decreases the surface tension. So just imagine this moist, warm little balloon. When it doesn't have air in it, it would tend to collapse on itself and stick. And you don't want that. You don't want the alveoli to collapse on themselves. So instead, you would secrete a surfactant that would prevent the sticking of the two sides of the alveoli. This is a diagram. So type 1 cells are the ones that are doing most of the lining of the entire alveolus. Remember, these are microscopic. And then you'd have the type 2 cell. There's one there, there's one there. They're sort of on the edges here shown, and they will secrete that phospholipid, allowing this not to stick together. And then there's macrophages here too, which are, anytime there's an entryway to the body, you want to have a macrophage there to be able to eliminate anything that lands in there that is not wanted. And it can eat it up and remove it. So just to be sure you understand the surface tension, this is what would happen to an alveolus if it was wet, humid, and warm. It would just close up on itself, and you don't want that to happen. So by decreasing the surface tension, what that means is that water wants to bind to itself with hydrogen bonds. So a surfactant will break those hydrogen bonds and decrease the force needed to inspire. If not, it would be a huge amount of force for you to bring air in if you're trying to inflate these deflated alveoli. Instead, they are not sticking together and they will remain open. This could be a problem in premature babies that are not producing enough surfactant. So it turns out that they begin producing the surfactant at about 25 weeks of gestation. So if they are beyond that, well beyond that, you know that those little lungs won't collapse. And they'll be fine. Those alveoli won't collapse. At 34 weeks, it's adequate level. So between that, it's still iffy. And what you would do in a premature baby that was under the 34 weeks, you would have to either try and accelerate the production of that surfactant, and you would do that with a corticosteroid, or you could also supply the actual surfactant, and these are usually given, it's pig surfactant that you can administer via intubation, and that way the baby could breathe without those alveoli collapsing. I wanted to show you though, all alveoli are not the same size. They come in different sizes, and you would need more or less surfactant depending on the size of the alveolus. So you would imagine that a large alveolus, at the first time you think about this, you would think, well, the bigger it is, the more surfactant it needs. But look at this. We use the law of LaPlace, which says the pressure that's going to be created there inside the alveolus is equal to, P is equal to 2 times T, the surface tension, divided by the radius. So this is what's going to matter, right? The radius is going to differ in these different alveoli that are of different sizes. So if you have this larger bubble, the radius is of 2, and we're going to compare it to one that's a radius of 1. So let's compare 2 alveoli, one larger, one smaller. The T, which is the surface tension of the fluid, is going to be the same because it's the same surfactant in both. And when we plug in those numbers, we see that the pressure created in a large one is equal to 3, and in the smaller one, it's equal to 6. So because it's tinier and those walls are closer together, they're more likely, right? They're more likely to collapse on each other the smaller they are. So the take-home message here is that in the smaller alveoli, there is a greater amount of surfactant released. Okay, so these little dots are showing how much surfactant needs to be released in a smaller alveolus as compared to a larger one. It's kind of counterintuitive when you first think about it. So just as a summary, the surfactant is more concentrated in the smaller alveoli, and that equalizes the pressure in the large and the small alveoli, so they need just as much pressure to stay in that open position. I'm going to stop it there. This is going to be the last slide of part 1, and then I will do another video showing more about that membrane and what barriers oxygen needs to cross to get across that membrane. Thanks for listening.